Welcome to our newest episode of The Animal Heartbeats, hosted by myself, Kieran, a veterinary cardiology specialist, and my fellow veterinary cardiologist and podcaster, Jose Novo Matos. We're talking on this occasion about mitral valve disease, focused on the prognostic indicators for dogs with mitral valve disease. In the last episode, we talked about assessing regurgitant fraction and how this may play a role in decision-making for surgical candidates. At the moment, we don't have the perfect way of assessing regurgitant fraction, and we discussed the pitfalls of echo assessment of regurgitant fraction last time. In this episode, Jose and I will be focusing on how to assess these dogs in the earlier stages of disease and how those assessments may influence our decision-making surrounding treatment, monitoring, and management of these dogs. And to that end, we're going to pick up where we left off last time, thinking about assessing mitral regurgitation severity in dogs with degenerative valve disease. Let's just take it a step back and think now more about the medical treatment, because this is what people are going to be doing, isn't it? And you know, we're interested and excited about these other procedures, but actually treating medically is fundamental to these dogs as a population worldwide. And we're saying that, you know, maybe LAAO can be challenging. Do we say that every dog in stage B1 should be seen once every 12 months, which is what the consensus statement says? Maybe there are things we can spot that make us a little more concerned about that patient, or maybe a stage B2 dog who's come in and is in stage B2, but they need some anesthesia or fluid therapy. What's our short-term risk assessment? What do you use in those scenarios? We've talked about the linear measurements and the volumetric assessment, I guess, of MR. So we've gone from the very basic assessment to the very advanced assessment, which is super challenging. Is there anything in the middle that you use?
Exactly. So mitral inflow is an important way to assess. Well, to assess left atrial pressure, when we measure, for example, mitral inflow with myxomatous mitral valve disease and severe mitral regurgitation, the peak velocity does not necessarily mean LA pressure. It may just reflect volume overload. But mitral inflow is an important variable to measure, and that's been shown repeatedly in many studies. And the delay study, I think the delay study was a great study also to assess echocardiographic variables and predictors.
Right.
For congestive heart failure. Exactly. And they showed that E velocity more than 1 meter per second, I believe, LAEO more than 2.1, and left ventricular diameter normalized to body weight more than 1.9 were independent predictors of congestive heart failure. So mitral inflow is something I lose a lot of time where is like our default measurement. Overall in echo, but the case you were mentioning. Then if I have a borderline left atrial size or left internal diameter, I like to assess mitral inflow and peak E velocity to assess left atrial pressure or filling pressures, if you want, or risk of congestive heart failure. Do you ever measure vena contracta?
It's a great question. I used to work with a cardiologist called Julia Sargent who did a lot of work on the vena contracta. She converted me to vena contracta and said, this is a great measurement. And the whole time she was doing this, the research, which is a great study, and that shows the prognostic value of mitral inflow as well, of Emax, as well as all of the stuff that's from the Borgarelli group as well. But in Julia's paper, they actually were looking at comparing echo measurements with the gold standard of MRI. This is the paper I'm talking about. She published a few in this area, but they're looking at the gold standard of MRI, which is great. This is the holy grail, isn't it? What can we do on echo that compares well to a gold standard? Vena contracta was something that, where I was working at the time, we loved this as a measurement, the idea that looking at vena contracta normalized for body size. So they normalized it for aortic diameter, like left atrium is normalized for aortic diameter. And basically, the bigger the vena contracta, so the wider the neck of the jet of mitral regurgitation, the bigger the hole and the worse the regurgitant fraction on MRI. And that's true. It corresponded very, very well with the MRI-derived regurgitant fraction. Another method, which I think we all hate as cardiologists, is something called jet area ratio, or JAR. So the jet area ratio, people often refer to it as dial-a-jet because it's so affected by the color settings and the 2D settings on your machine that you can make quite bad regurgitation look quite small, and quite small regurgitation look much larger than it really is. So, you know, if you're going to use comparing the size of the jet or the area of the jet to the area of the left atrium, which is how to perform that measurement. Or if you're just going to assess it subjectively and go, wow, that's a big jet, you need to get your settings right and repeatably the same across different patients. We all thought that, in this research that Julia was doing, the jet area ratio would perform really poorly. Actually, it performed quite well too, which was a bit sad because it's not what we wanted to see. But Julia's settings were very repeatable, exactly, and she got very good at it. So actually, the message there is probably get your settings right and look at it. Now, for all that I've said that I like the idea of vena contracta and how well it performs, do I measure it routinely? No. Yeah. It's an additional measurement that I don't think brings anything to me because I'm really happy with the mitral inflow. But maybe there are people out there who aren't so happy with their Doppler measurements or don't have access to pulse wave Doppler potentially on their machine, but maybe they've got color. In which case, you could probably measure a vena contracta.
The same. I generally do not measure it. I like to have a subjective assessment of it. I like to look at it.
I like to get the pictures for it, right?
Exactly. Yeah. No, just exactly. And looking at it and see, as you were saying, I also like to have a subjective assessment of how big is the mitral regurg in proportion to the LA size without measuring the area, and then look at the vena contracta. Of course, the vena contracta, as any other measurement, to have problems, depends on orifice geometry, may also change across the cardiac cycle and so on. But I like to have an idea of subjective idea, or is especially in case where again equivocal cases. But I would generally do not make decisions on that. So to summarize, LAO, left ventricular diameter, mitral inflow, LV fractional shortening. I bring that because there was the group from Dr. Dominic, Oriol Dominic in Ovara, they described these MIND score. So MIND score stands for mitral insufficiency echocardiographic score. And this is a severity score. Very good idea, great idea. They picked standard echocardiographic measurements that everyone is doing, and they combined them to create a score. And they use LV fractional shortening. So what's your opinion on that? Do you ever look at LV fractional shortening to determine severity of the disease, or not really?
Oh, so, I mean, if you've got mitral regurgitation, you've got a lot of blood coming into the ventricle from the atrium in diastole. And then obviously the stroke volume is artificially increased because there's blood going backwards into a low pressure chamber of the left atrium during systole. So the fractional shortening should be hyperdynamic in these dogs. The problem is, as the disease advances and it gets worse, the fractional shortening will reduce because the function will deteriorate. And eventually the fractional shortening may normalize or become subnormal. So the problem with fractional shortening is if you look at it by itself, you don't know what it means. You can't measure function in these dogs. And I think actually, measuring fractional shortening, measuring function with fractional shortening is pretty poor anyway. Do I do it? Is it part of the picture? Yeah, sure. In DCM and systolic dysfunction. But with any dog that's got significant mitral regurgitation, whether it's a bad DCM or a PDA or anything, using those two-dimensional functional estimates is terrible. It's just thrown completely out. And especially with mitral valve disease, when it gets bad, as I say, it sort of is a bell-shaped curve where the fractional shortening increases early in disease and then drops late in disease. I don't know how useful it is. I guess if I see a dog with huge left atrial size and huge left ventricular size and the fractional shortening is normal, well, that's bad because it means the function is very low. But if the fractional shortening is hyperdynamic, so 50, 60, 70, well, I would expect that. And I don't know what that means. And I don't know what it should be if the function's normal. So it doesn't really help me. I see why it's included in the score, but I don't know that paper very well, I have to say. And I'd be very interested to know how they dealt with that bell-shaped situation. Are they just looking at dogs in stage B1, B2? Because if they are, then probably the larger the fractional shortening measurement or the greater the fractional shortening measurement, the worse the mitral regurgitation fraction. Do you ever use it?
When Tommaso, the first author, great guy, doing a lot of
he's doing some great work, isn't he?
Yeah, great work. And when they first describe it, we start using it, and we asked the residents to start reporting it. Because what I like sometimes when we have these new papers is to gain experience with those new methods. So then
try it, and if you don't like it, then use it.
Then you can have a good opinion about it.
Absolutely.
So we start writing the MIND score on our reports and so on, and then whenever we see the dog back, we will compare the mind scores and so on. And
Nice.
I think my only issue with the mind score is that if I don't think I would have included LV fractional shortening.
Right.
And I think that the score makes it as the more hyperdynamic the LV is, the highest the score. So the more
Sure. And that makes sense, doesn't it, for early disease?
Exactly. But then, as you were saying, the problem is when there is that plateau and so on. But I think most importantly, as you were saying before, it's a great idea. And we have, I think, well, I'm sorry that I bring cats to every episode, even though there's nothing.
We should play like the animal heartbeat bingo. So, or a drinking game or something. So people listening should, when Jose mentions feline cardiomyopathy, take a drink,
Yeah, exactly. You'll be drunk very soon. It's just because we need something like that in cats. Instead of just say LV wall thickness, more than 6 millimeters.
Oh, yeah.
Cut off, the holy grail, or 5.5, whatever, to use to have a score, to have combined measurements. So as they did with mitral valve disease. So I like these scores because I think they make sense. But I agree. I think I generally do not look at LV fractional shortening, and maybe I would like to see this data without LV fractional shortening, but I believe the group is collecting data now for longitudinal data.
Like a validation. I think any of these sort of new kind of methods of looking at echo, it's important when you're researching to do a derivation cohort and a validation cohort, because you might derive them from a population of dogs and it looks great. And then you validate it in a different population of dogs, and because the population is different, well, maybe it doesn't. Well, it won't perform as well. That's just the nature of it. It won't perform as well. And there was a nice paper a few years ago now. God, I can't remember what it's called. But they were looking at using NT-proBNP and some other things to look at severity of mitral regurgitation and progression of disease. And they used a scoring system. And in one paper, they did derivation validation, and the derivation cohort had an accuracy of, I think, 85% or something, which is pretty good. And then in the derivation cohort, it's more like 70. In the validation cohort, it was more like 70. So of course, it's always going to drop when you apply it to different populations. Just to play devil's advocate about these scoring systems, whether it's the MIND score or something, looking at other disease. With the MIND score, we're looking at things like Emax, left atrial size, left ventricular internal diameter. I would argue they're all interrelated, because obviously you have worse mitral regurgitation severity that drives all of those things.
Yeah.
So surely these scores are going to change exponentially.
Yeah.
It's not like it's going to be a straight line on a graph with increasing score and worsening regurgitation fraction. It's going to be an exponential curve. So as the mitral regurg gets worse, the score is going to amplify and amplify and amplify. So there must be a point at which suddenly it's a tipping point and the score suddenly increases. How do we deal with that? Because it means that probably they're not going to be very sensitive to change. They're going to suddenly change, and that's my problem with it. The other thing is that statistically, of course, that they're not really independent predictors, or not all independent predictors. They're going to be very related to each other.
Exactly. So multicollinearity. So that's why we need multivariable analysis and a model that we are sure that the factors that try to predict the outcome are independent. Totally agree. And thinking about the delay study, they showed that. So in their final model, they exclude left ventricular diameter because that variable was highly correlated to LA size, as you were saying. It's complete sense. So in their final model, they had LAO, Emax, and NT-proBNP, which I want to ask you in a second about it. But so that's incredibly important, that when we define a score, that we avoid factors that are measuring the same thing. Because they increase or decrease. One is related to the other. So mitral valve inflow, peak E velocity, LAO, clearly are independent factors.
That they are different things.
Many studies. And so I think those are certainly very, very good, two very good variables. So in each of our episodes, we discuss biomarkers. And this, of course, is important because...
And so far, we haven't really used them, right?
True, but we always talk about them. Well, of course, you work as a cardiologist in a referral center, so it's a different population and approach to cases. But do you think there is any place to measure NT-proBNP in a primary care setting?
I'm going to reference the work of a former colleague and friend of mine, Melanie Hazel, whose PhD was looking at mitral valve disease in a longitudinal population of dogs. And she produced some very nice work, some of which was looking at fibrosis, looking at spironolactone. But actually, one of the big papers that jumps out for me is looking at NT-proBNP and troponin and cardiac death. in terms of prognostic factors, you can't really argue with an endpoint of cardiac death, can you? Because you're dead or alive, and it's difficult to quibble with that. She reported in that paper that actually the absolute concentration of NT-proBNP or troponin wasn't associated with outcome. However, the rate of change was. So in the population of dogs that suffered a cardiac death, the rate of change of NT-proBNP and troponin was greater, but the rate of change of NT-proBNP was greater in earlier disease, and the rate of change of troponin was much greater in later disease. So that means that if you measure a cardiac biomarker once, even if you put them in combination with each other, they're not that useful. But if you measure them every 6 months, as Melanie did in her paper, then actually it did show that you could tease out the higher risk dogs. I guess the question that comes from that is, what do we do with that? If we are in primary care practice and we're using these cardiac biomarkers to monitor these cases or monitor risk, I guess, in these cases, we don't know from the cardiac biomarker rate of change, which is stage B1, B2. We don't know when to intervene with the rate of change of cardiac biomarkers. So for me, I would say if we're using those biomarkers to look at rate of change and therefore stratify risk in our patients. So we say, you know what, Mrs. Jones, poor Charlie's a cavalier. Charlie, his NT-proBNP has increased and his troponin's really jumped. We're worried that he's going to die in the next 6 months. And then Mrs. Jones says, oh my goodness, so what do? And we go, buy a small bag of dog food. I mean, I don't know what to do with that. So I'm not saying that information is not important. And I think communicating our expectations of longevity and of quality of life are important to owners, because it's important for them to think about what's happening and be aware of what's happening and not be blindsided. But equally, if it doesn't change what we do, how useful is it? And actually, should the fact that the dog has an increase in dose of furosemide because of its heart failure be enough to make us say the prognosis is poor? I don't know. What are your thoughts? Do you use them? Do you recommend using them?
No, I do not. I do not use them, and I generally do not recommend them to primary care vets. As you were saying, I think Melanie's work is really interesting, more to assess the rate of change and so on. I think what is interesting, again, from the delay study is, because it's very cool, and again, we cannot do that in cats. It's very cool that to predict heart failure. When will they? Because we see B2s, and then as you were saying, B2 has a very big range of dogs and LA size and so on. And then people have suggested in the past to try to maybe split B2 into different groups.
We just don't need a B3, do we?
Exactly. We don't. But just to say, to reflect that B2 is a very, very big group of cases. Yeah. And then what I think Mrs. Jones was she? Yeah, exactly. So what
Charlie Jones, yeah, exactly. An 11-year-old male neuter Cavalier King Charles Spaniel.
Exactly. So what she really wants to know is, it will be interesting to know, when does Charlie go into congestive heart failure? And to determine that, I think is very, very cool and very useful in any heart disease. So I think the risk of congestive heart failure within 6 months from the delay data show that an NT-proBNP more than 1,500, these dogs had an increased risk of congestive heart failure. So I think that's an interesting question. It's an interesting question, something that clients may ask. And so again, combining echo data and saying, okay, it's a big left atrium, more than 2.1 if you want, a big left ventricular diameter, NT-proBNP more than 1,500, the risk of congestive heart failure in the next 6 months is very high. And again, I think this is important for clients, because we all teach them to measure respiratory rate and so on. So to tell them, how worried should you be? Because if it is an early B2, you may say, but you will not go into congestive heart failure probably in the next 6 months or 9 months. But then if it's a case that you clearly the risk of congestive heart failure is very, very high, and you may say, well, I don't need NT-proBNP for that. My echo variables, my echo will tell me that, and I agree. But I think that question is an interesting one from research point of view and clinic point of view. What's the risk of congestive heart failure in the next 6 months? Because I think that's a very important point for clients, for vets.
And that's where rate of change of heart size comes in. Yeah, true. Because in all the work by Peter Lord back in the 90s, and Boswood has looked at this as well. As the heart gets larger, it's the rate of change that predicts, or the rate of change in the 6 months before heart failure suddenly increases. It rapidly increases, and I think that's where rate of change of imaging variables is important. There's probably a utility of cardiac biomarkers there too, but the day-to-day variability is just so much, especially in an NT-proBNP, that I don't use them, and I don't recommend people use them. I would rather people, instead of practicing how to interpret biomarkers, just practice how to measure left atrial size repeatedly, because if you can do that, or even took a baseline radiograph when the dog's not in heart failure, miles away from heart failure, first detect a murmur, and then use your radiograph, that baseline, as your reference marker, and you monitor the radiographic change. Initially, if the heart's not big, you can take a picture in a year, tie it in with a routine appointment or something. And then if you think the heart's beginning to enlarge compared to your baseline radiograph, then take it in 6 months. And once they're in B2, start treatment, and then continue taking radiographs. And if one day you suddenly notice a massive jump, then you amplify your respiratory rate monitoring. Maybe you give them some furosemide to put at the back of the shelf so they're ready to reach for it. So I think rate of change is very important for prognosis. And it's something that's probably most important for predicting heart failure.
Imaging, exactly. Imaging. We need imaging. X-rays, absolutely totally agree. I think we are close to the end of our podcast. Something that we do not talk about, like negative prognostic factors that are clear, is stuff like atrial fibrillation, dogs with advanced disease and
bad pulmonary hypertension.
Pulmonary hypertension, exactly. Some very nice work from Bargarelli there also. What I wanted to ask you is, so sometimes if we rely on LAO, in some cases, the left atrium will not dilate in an homogeneous pattern.
Right.
Describing it properly. Sometimes there is a huge bulge in the intraatrial septum has a huge bulge. I think I heard someone calling it like a pancake shape. I'm not sure.
My pancakes are perfectly round. I don't know.
Sure, well, not my pancakes. But so the intraatrial septum, we see that, isn't it? That one diameter looks rather normal or mildly dilated, and they dilate in a very heterogeneous way or not homogeneous way, and they may as an example, the atrial septum is huge, or the left artery.
Sure, they're often a trapezium shape, aren't they? In that long axis view. Yeah.
How do you approach those cases?
I try and find the maximum diameter where I'm not in a pulmonary vein. And that's true from the long axis as well as the short axis view. I really try to avoid the pulmonary vein. And I try and, especially in short axis, try and define my landmarks really clearly. There's that sort of bump on the left atrial wall, which is probably part of the sinus venosus valves or something that's regressed between the pulmonary vein to the sort of lateral aspect of the image and the body of the auricle. And I try and measure to that bump. And I try and, when I measure left atrial size in short axis, and I try and measure that bump very repeatedly every time. So I use an anatomic landmark rather than that whole extrapolating into the pulmonary vein thing that people do, which I think is just guesswork. Certainly in my hands, it's just guesswork. And I think in long axis, I try and get the maximum where, again, I believe I'm not in the pulmonary vein ostium. And I try to measure parallel to the mitral annulus in order to standardize my measurement. Have you got any tips?
No, I agree with you. I think these odd-shaped left atriums are a good example that we should not only rely on one measurement, and LAO may not give you the whole picture. And so I think Visser's data, as you were saying, and measuring LA diameter in long axis would at least estimate that axis and if the intraatrial septum is bulging a lot towards the right atrium, the left atrium dilated in an odd shape, you're going to detect that enlargement. And I guess this would be again another argument to look at regurgitant fraction,
right?
Because then in those cases that will probably give you a very, very different picture.
I think if there was a reliable, repeatable way of us measuring the actual volume that's going backwards through the valve, that's bound to be the best way, because that drives everything else. The problem is we don't have that at the moment. We have some best guesses. So I think we're coming to the end of our podcast episode in the interest of time. People have finished their commute or maybe need to put the kids to bed or whatever people are doing around this podcast. It's time to summarize and think about the key messages of prognostic variables. I think stage B2 is of prognostic importance, not only, in decision-making for treatment. It does identify dogs with the worst disease. Left atrial size, left ventricular internal diameter, they are reasonable measurements to make, and they are very useful across a large number of dogs. They're accessible measurements. They are what the decision-making and the evidence base of treatment in the preclinical phase are based upon. I think if you want to go beyond that, and in some cases it's very important to go beyond that, I think level 1 is probably maximum velocity of early diastolic mitral inflow, the Emax measurement. If that's greater than 1 meters per second, 1.2, 1.4, those are much worse mitral regurgitation severities. The blood that goes backwards must come forwards, and that volume loading drives that increase in velocity. If you wanted to advance things even further, then using rate of change of those imaging variables, the heart size, to predict the onset of congestive heart failure is very useful. And I think ultimately, if you're getting very interested in echo or want to challenge yourself with your echo assessments, I think trying to estimate regurgitant fraction itself and measure the disease itself is probably the thing to do. There is a place for vena contracta in there. I think there may even be a place for jet area ratio, looking at the color Doppler. But the biggest challenges are volumetric and PISA-based methods of estimating regurgitant fraction. Give it a go, see what works for you, and find something that works in your hands that is repeatable on the same dog. And then you can use it to track change over time. Any final comments, Jose?
No, fantastic. I think you summarize it very, very well. Great. So I hope everyone enjoyed our podcast. Stay tuned, and we'll be back soon.
Thanks, everybody. Don't forget to follow us on social media. Twitter and Instagram are both at heartbeat_pod. Please share with us any ideas for guests, future episode topics, or any questions that you might have along the way. Thanks very much.
Have a great day.